Robin Hoffman, Mike Gibson, talking about the newest in the Sweetheart Registry series, this one called HELP-MI. Robin, talk to us a little bit about what you did and why you did it.
Yeah, thank you, Mike. Thanks for having me. Well, we performed this nationwide cluster randomized crossover registry-based clinical trial to investigate on the healthcare level in 18,500 individuals from 35 hospitals if adding routine H. pylori screening by bedside urea breath test to usual care prevent upper gastrointestinal bleeding events after a myocardial infarction.
And so to talk to us a little bit about what's the prevalence of H. pylori in the Swedish population, and what were you hoping to prevent?
Yeah, thank you. That's a good question. When we started this trial, when we planned it, we had no idea. And then it turns out that in the underlying population, it's somewhere between 10 and 15%. And in a current myocardial infarction population, in a pilot study, it was 20%. In our trial, it was actually 24%. So one
Wow.
fourth of the individuals were
Wow.
Helicobacter pylori positive.
Now, of course, we always think of it as causing bleeding. Is there any data out there to suggest that it may be involved in a thrombotic process?
That's also a very insightful comment. It's mostly about bleeding, in particular in conjunction to antiplatelet or antithrombotic therapies. But there is some indication that maybe Helicobacter by itself, due to inflammatory processes, also could be pro-thrombotic, actually.
Well, there are some studies looking at plaque and looking at bacteria within plaques.
Mm.
We do know sometimes certain bacteria may play a role in the pathogenesis of plaque rupture. So higher risk of bleeding in these 24% of people. Talk to us about then how you treated them and what you found.
Yeah, so we found Helicobacter in 24% of the individuals during the screening periods, and virtually all of them were treated with eradication treatment, which is in Sweden a standard triple combination of antibiotics and proton pump inhibitors. And in the primary analysis, which involves the intention to treat population, which is everyone, and here I need to stress this is the 85% of the whole Swedish underlying myocardial infarction population, we found a 10% relative risk reduction in the incidence of upper gastrointestinal bleedings, but that was not statistically significant. However, in pre-specified subgroups, we found that individuals who had anemia at baseline, which was 15% of the population, at baseline, which was 25% of the population, they had a significant interaction indicating a screening effect of H. pylori.
Fascinating. So, the PPIs can interfere with antiplatelet agents. So was it the treatment of H. pylori, or did you downregulate or down titrate the effectiveness of the antiplatelets? So was there any increase in thrombotic events?
There was, if you look at the individuals in the per protocol population, we only looked at the screened individuals and the screened individuals who were treated. And there you can see both a much stronger screening effect with concern to bleeding. It was a 50% relative risk reduction, but also a stronger effect on the secondary outcomes, which were cardiovascular outcomes, although those were not statistically significant. And there one may wonder if our follow-up period of it's an average 2 years was a bit too short, because I would imagine that those effects maybe are clearer after a longer follow-up. Because of course there's two aspects, one is the bleeding by itself can cause
Right.
issues, and also that you de-escalate or maybe completely stop antithrombotic bleeding, antithrombotic therapy during a bleeding event. So this is very important things to follow, and this is also one of the assets of our trial, that we have the opportunity to follow the patients virtually for life, and that's both for mortality but also for all sorts of hospitalizations.
So what do we make of this? Didn't quite make it on the ITT, makes it on the per protocol. What do you think? Did you succeed? Should we be adopting this in clinical practice or not?
Yeah, that's the $1 million question, I would say. You know, the discussant at the ESC, Professor Paul Ritger, his idea was that this was likely a positive trial. And I think we should leave it to the guideline committees to decide. As a cardiologist, personally, I believe we have very sound evidence to suggest that people at increased risk of upper gastrointestinal bleeding will benefit of this very simple, very safe test. You know, there's not much risk, it's not very expensive, and the potential benefit is large.
Well, I would support that conclusion. I'm very envious of all of you in Sweden. You always have the chance to study large numbers of people, have very low rates of missingness because it's all part of your national healthcare system, and you answer interesting and important questions. Robin, thank you so much for joining us today. That was fascinating.
Thank you very much. Bye bye.
Bye-bye.